Hello everyone and welcome back. So in this video we will discuss a subarachnoid hemorrhage topic. We will discuss how it occurs and what are the investigation options and treatment options for this disease. So this is been and it is covered in three layers, that is pia mater, arachnoid and dura mater. The different hematomas that occur among these three different layers are named as extradural hematoma, which occur in the dura mater, and then subdural hematoma, and then the subarachnoid hematoma, which occurs between the arachnoid and pia mater, and the subdural hematoma occurs between the dura and the arachnoid mater. So what are the causes of the subarachnoid hemorrhage? So this is the subarachnoid hemorrhage, which is occurring between the arachnoid and the pia mater. So the causes are hemorrhagic stroke, that is hemorrhage occur and stroke happens. This leads to the subarachnoid hemorrhage. Then Barrett's aneurysm is also a cause which leads to the hemorrhage in the brain. This is the circular villus and it contains anterior cerebral artery, middle cerebral artery and posterior cerebral artery. So the aneurysm, if occurs in this, then this leads to the subarachnoid hemorrhage. Now the most common circular aneurysm is from anterior communicating artery, and on second common is posterior communicating artery, and on third is middle communicating artery. These three are the most common causes of the subarachnoid hemorrhage. On the first number is anterior communicating artery, on the second number is the posterior communicating artery, and on the third number is middle communicating artery. This leads to the subarachnoid hemorrhage. The rupture of these leads to hemorrhage. These are the three arteries which are more prone to the hemorrhage, and this leads to subarachnoid hemorrhage. AV malformation and vasculitis is also the cause of subarachnoid hemorrhage, and amyloid angioplasty is also a cause of the subarachnoid hemorrhage. So we have discussed the most common causes of the subarachnoid hemorrhage, which are hemorrhagic stroke and Barrett's aneurysm. And the most common arteries are anterior communicating artery, common posterior communicating artery, and middle communicating artery. Then we have AV malformation as a cause of subarachnoid hemorrhage and amyloid angiopathy. Now, what are the clinical features of the subarachnoid hemorrhage, or the patient of the subarachnoid hemorrhage will present with which signs and symptoms? We will discuss this. So these are the sudden onset of severe headache in occipital region. Remember this. These clinical features will help you to differentiate the subarachnoid hemorrhage from stroke. So in subarachnoid hemorrhage, severe headache in the occipital region will occur, vomitings and signs of the meningism, blurred vision, raised intracranial pressure, delirium, pain in neck, loss of consciousness, Brudzinski's and positive connect signs, irritable to light, and very less chance of the body weakness, that is hemiparesis. These are the clinical features that will help you to differentiate the subarachnoid hemorrhage from the stroke. Hemiparesis is the most common clinical feature in the stroke, but in case of subarachnoid hemorrhage, it occurs sometimes or very less. The main clinical features of the subarachnoid hemorrhage are vomiting, meningism, blurred vision, raised intracranial pressure, delirium, pain in neck, loss of consciousness, Brudzinski's and connect signs, irritable to light, and very less chance of the body weakness. On fundoscopy, there will be increased raised intracranial pressure, there will be papillary edema, and there will be hemorrhage in the eyelid space. These are the common features on fundoscopy. Third nerve palsy, sometimes eye movement and loss of the eye function. Okay, as hemorrhage occur in the subarachnoid space, so third nerve palsy may occur, which leads to the loss of the eye function. So this is also one of the main feature of the subarachnoid hemorrhage. This is the main differentiation point, that is hemorrhagic stroke is due to hemiparesis and subarachnoid hemorrhage is due to the signs of meningism, Kernicks and Brudzinski's signs, and neck pain. Now the investigations that are done are CT scan, that is which shows hemorrhage, and this is a diagnostic investigation for the case of the subarachnoid hemorrhage. This is a general picture of the CT scan. It is shown at central area basal ganglia. So this is the internal capsule, this is the putamen, this is the thalamus, this is the candidate nucleus of the brain, and this is the basal ganglia. The subarachnoid hemorrhage occurs here. That is hyperdense white hemorrhage will be shown on the CT scan, which is made in the corner view. These are the wide areas. Subarachnoid hemorrhage form in all those areas where there is CSF. So the diagnostic test is CT scan. This is the general picture. These are the anatomical regions of the brain. That is, the here caudate nucleus is present. Here internal capsule is present. Here basal ganglia are present. There is putamen, and here is thalamus present. And this is the subarachnoid hemorrhage. So the hyperdense white hemorrhage that is shown in the CT scan will show us that this is the subarachnoid hemorrhage. This is the white area, and the subarachnoid hemorrhage form in all those areas where there is CSF. LP puncture is done, and it is 12 hours after the symptoms onset. This is also diagnostic, and it is for before doing it must rule out intracranial pressure. If raised intracranial pressure, then it can lead to pressure brain conning. So before doing the lumbar puncture, first find out the intracranial pressure is normal or raised. If it is raised, then LP puncture is contraindicated. LP puncture is done to look for blood in the CSF, that is xanthochromia. Okay, the third investigation is cerebral angiography, that is dye is injected in the brain vessels and X-rays are taken, and it confirms the vessels hemorrhage to confirm the diagnosis. So we have discussed the three main investigations, which are CT scan and MR or LP puncture and angiopathy, cerebral angiography. So these are the normal anatomical structures of the brain, that is caudate nucleus, internal capsule, putamen, basal ganglia and thalamus, and between these areas the subarachnoid hemorrhage will be present, which will appear as hypertense white hemorrhage area in the CT scan, and all those areas where CSF is present there will be subarachnoid hemorrhage. Then LP puncture is done in case of normal intracranial pressure, and then it is find out whether the blood is present in CSF or not. Cerebral angiography is done, a dye is injected in the brain vessels and X-rays are taken to confirm vessels hemorrhage. These are the management options, that is nimodipine is given, which is calcium channel blocker, and it is antispasmodic. This is given to prevent vascular spasm, which can lead to ischemic stroke. As subarachnoid hemorrhage can do further brain ischemia, so antispasmodics are given, which prevent the brain from vascular spasm. So for this purpose, nimodipine is given. This is an antispasmodic. The dose is 30 to 60 mg intravenously, and it is given for 14 days. Then treat according to the cause. For example, if the cause is aneurysm, as we have discussed, then clipping is done. Platinum coil is another option for this aneurysm, and if arteriovenous malformation is present, then surgical approach or ligation and injection of the material of occlusion is done. These are the various management options. So as we know that due to subarachnoid hemorrhage, further brain ischemia can occur. So for that purpose, we will give the calcium channel blockers, that is antispasmodics, which is nimodipine. Then we will treat the cause, and if the cause is aneurysm, then clipping is done. If clipping is one option, but recurrence can occur due to clipping, so the another option is platinum coil, and there is no recurrence in the platinum coil. If the cause is arteriovenous malformation, then surgical approach is done, and ligation is done, and injection of material of the occlusion material can also be done in the case of subarachnoid hemorrhage. Now, how we will manage the complications of the subarachnoid hemorrhage? The complications are hydrocephalus, that is obstructive hydrocephalus, and which is due to increased pressure. So drainage shunt, that is cranioperitoneum shunt, and CSF drain in peritoneal cavity is done. If the hydrocephalus, obstructive hydrocephalus is created, then drainage shunt is injected and CSF drain in peritoneal cavity is done. If delayed cerebral ischemia occur, then due to vessel spasm increase and vasodilators are given for this purpose. If hyponatremia occur, then fluid restrictions are done. And if systemic complications are occurred, that is bedridden, aspiration, pneumonia, and bed sores. These are the systemic complications of the subarachnoid hemorrhage. So we have discussed the complications of subarachnoid hemorrhage, which are obstructive hydrocephalus and delayed cerebral ischemia and hyponatremia and systemic complications. So care should be taken for systemic complications, that is bedridden patient and aspiration, pneumonia, and bed sores. For hyponatremia, fluid restriction is done, and for delayed cerebral ischemia due to vessel spasm, increased vasodilators are given. And for obstructive hydrocephalus, drainage shunt CSF drain in peritoneal cavity is done. So we have discussed the case of subarachnoid hemorrhage, that how it occurred. When the hemorrhage occur between the arachnoid and pia mater, this is subarachnoid hemorrhage, and these are the causes. There is hemorrhagic stroke, and there is aneurysm and circular aneurysm. And the most prone arteries are anterior communicating artery, posterior communicating artery, and middle communicating artery. Also, AV malformations and amyloid angiopathy. These are the causes. And the clinical features are severe headache, vomiting, meningism, blurred vision, raised intraocular pressure, delirium, and pain in the neck, the loss of consciousness, and Budzinski's and chronic signs, and irritability to light, and very less chance of body weakness, that is hemoparesis. Then fundoscopy is done, and there may be papillary edema and hemorrhage in the eyelid space. How to differentiate the hemorrhagic stroke and subarachnoid hemorrhage? These are the important things. And the investigations options are CT scan. On CT scan, there will be hyperdense white hemorrhagic areas in the this area. And these are the abnormal anatomical areas of the brain, and wherever the CSF is present, there will be subarachnoid hemorrhage, that is, the blood will travel in the CSF. LP puncture is also done, which is a diagnostic, and it is done to find whether the blood is present in the CSF or not. But before doing that, it is confirmed that intracranial pressure is normal. Cerebral angiography is done, dye is injected, and brain vessels are watch for if there is any blood or not. The management is the antispasmodics are given to prevent the further brain ischemia, that is nimotipine. And the cause is treated, that is clipping is done, or occlusion material is given, or platinum coil is given, or surgical approach or ligation is done. For the complications management, if it is hydrocephalus, then drainage is done. If it is delayed cerebral ischemia, then vasodilators are given. If hyponatremia, then fluid is corrected. And for the systemic complications, care of the patient is taken. So this was all about the subarachnoid hemorrhage. Thanks for watching.